Bismillah ar-Rahman ar-Rahim. Viral skin diseases. Viral skin diseases, the most important is herpes group, herpes simplex, herpes zoster, and molluscum contagiosum, warts, and we will see in details. Viral skin diseases are, we will talk about general considerations. Viruses are obligatory intracellular parasites. They can differ from bacteria. They differ from bacteria by lacking organelles. So they don't possess functional ribosomes or other cellular organisms, so they must use organelles of the host cell for their replication. They are obligatory intracellular parasites. Each virus is classified broadly into bacterial, plant, or animal virus based on the type of the cell it infects. And animal viruses are divided also into several large families based on the viral morphology, nucleic acid composition, as we will see down the families. The viron is composed of, or the structure of the viron is, there is the viral genetic core, RNA or DNA, and there is the protein coat or the capsid, surrounded by a protective coat or capsid formed of capsulomeres, and also in certain virus families as herpes virus and retrovirus, the capsid is located inside an envelope. So the viral envelope, it is formed of lipid and glycoprotein. This is required for its infectivity, and the envelope is sensitive to drying, so infectivity is lost on drying surfaces. Also, there is a comment that the viruses like papillomavirus do not have capsid. They do not have envelope. So they are naked. The capsid is stable on dry environment, so they remain infective for long periods of time. So the viruses are obligatory intracellular parasites. There is large families. The animal viruses have large families, and the viron composed of viral genetic core, RNA or DNA, protein coat, capsid formed of capsulomeres, and the envelope, which is lipid and glycoprotein, which is lost by drying. The envelope, the herpes virus have envelope, and the papillomavirus are naked only, they have the capsid. Now we will talk about these families we're talking about now, the families of DNA and RNA viruses, or classification of viruses that can infect skin and mucous membrane. The DNA viruses, herpes virus group, and papillomavirus group, pox virus group. The RNA viruses, paromyxoviruses like measles and mumps, picornavirus like Coxsackie virus, hand, foot, and mouth disease, and retrovirus like human T-cell lymphoma virus and HIV. This is the RNA viruses. DNA viruses, we'll talk in some details. The herpes virus group, they multiply intracellular, and the papillomavirus group, they multiply intracellular, intranuclear. So the herpes virus group, intranuclear. The papillomavirus group, intranuclear. The pox virus group is intracytoplasmic. So the herpes virus group multiply intranuclear. The herpes virus group actually is 7 types. 8 مالهمش تاسع. Herpes virus group, herpes simplex virus type 1, herpes simplex virus type 2, and herpes virus 3, which is the varicella zoster, and herpes virus 4, which is the Epstein-Barr virus, and herpes virus 5, cytomegalovirus 6, herpes virus 6, which is responsible for roseola infantum, and the herpes virus 7, responsible also for roseola infantum and pityriasis rosea. The herpes virus 8 is responsible for Kaposi sarcoma. So this is the herpes virus group, which multiply nuclear. There are 8 ما لهمش تاسع. herpes simplex virus type 1 and type 2, varicella zoster. 4 and 5 Epstein-Barr virus and cytomegalovirus. 6 and 7 responsible for roseola infantum, and 7 roseola infantum and Petrus rosea. 8 is Kaposi sarcoma. The papilloma virus multiply also intranuclear. This human papilloma virus, they are paporavirus group. And the pox virus group, they multiply intracytoplasmic. They multiply intracytoplasmic, and 3 types of pox virus group, or orthopox, which is responsible for smallpox, and the parapox viruses, which are myxoviruses, responsible for the Orff and Melker nodule. They are both, 2 viruses are similar morphologically and serologically, but differ by PCR. And unclassified the molluscum contagiosum. As we can see here, it is present in the cytoplasm. So intracytoplasmic. The pox virus, the orthopox virus, variola virus, smallpox, the parapox virus or the myxovirus responsible for the Orff and Melker nodule, the molluscum contagiosum virus, which is in all the pox virus group intracytoplasmic. This is the 3 DNA viruses: herpes virus group, papilloma virus group, and pox virus group. What about the RNA viruses? We said that there is the RNA virus, the paromyxovirus, measles and mumps, and picornavirus, Coxsackie virus, hand, foot, and mouth disease, retrovirus, human T-cell lymphoma virus, and HIV disease. This is a picture of the electron microscopy of the papilloma virus, the pox virus, and the herpes virus. The papilloma virus to the which were the capsid and capsomeres only, also the pox virus we can see to the right up, and C is herpes virus with the capsid and envelope. Immune response to viruses. We will talk about immune response to viruses regarding humoral antibodies, cell-mediated immunity, interferon, and viral replication and inclusion bodies. The humoral antibodies, primary response, slow appearance of small amounts of immunoglobulin M remains for 6 to 8 weeks, and secondary response, large amount of immunoglobulin G that persists for a long time. The primary response occurs as a slow appearance of immunoglobulin M antibodies. The secondary response, a large amount of immunoglobulin G antibodies. The first primary response for 6 to 8 weeks, and the secondary response for long life. And the secondary response, of course, it happens seconds and subsequent to exposure to the same viral antigen by nature means or by booster dose of vaccine. Major role of circulating antibodies is to prevent reinfection of the same virus and prevention of spread of the virus from the site of infection. So the major role of circulating antibodies, prevention of reinfection and spread of the virus. Second, the secretory immunoglobulin G antibodies may play a role in gut and genitourinary tract immunity. The duration of immunity induced by viruses varies from measles, mumps, like long life immunity, and respiratory viruses, short-term immunity. This is the humoral antibodies, immunoglobulin M and G, and in other places like the gut, like immunoglobulin A. Cell-mediated immunity, this happens during the latency period where it is induced by some viruses followed by primary infection. Viruses are controlled by cell-mediated immunity. So when cell-mediated immunity is inhibited, like immunosuppressed, compromised patients or immunosuppressed or malignancy, this leads to recurrence. The interferon is produced by infected cell to prevent spread of infection. So it's produced by the infected cells to prevent spread of infection. There is a little also details in that. that inflammatory cells also may produce some of the antiviral effect by the production of interferon, which is a unique family of closely set cytokines which are active against viruses. Interferon, which can be induced by foreign RNA or DNA induced by viral nucleic acid, is secreted into extracellular fluid. Resistance to the virus infection is induced in these cells that come in contact with the interferon. All viruses capable of inducing interferon and are susceptible to its action, but differ in the degree of interferon induction and their sensitivity to its action. So, first, the humoral antibodies, primary immunoglobulin M and for 6 to 8 weeks, and secondary immunoglobulin G for lifelong and long time, and there is immunoglobulin A in the gut and genitourinary tract, and cell-mediated immunity, the latency period, and when it decreases, this leads to recurrence. The interferon, either from the infected cell or from the virus itself, can induce, prevent spread of infection. Viral replication. Viral replication, first attachment of the virus, specific receptors on the cell membrane, then entry in 3 steps: fuse with the host cell membrane, uncoating of the protein coat of the virus is removed by the host cell enzymes, and release of viral nucleic acid. So first fuse, uncoating, and then release. Next step depends on the nature of the virus. In DNA viruses, DNA transformed into messenger RNA and give rise to structural proteins and nucleic acid and assembly into new virins. In RNA viruses, RNA acts by messenger RNA immediately and translated into structural proteins and nucleic acids. And in retrovirus HIV, the RNA is transferred into double-stranded DNA by release of transcriptase in cytoplasm, and then enters the nucleus and incorporated into host DNA and forming messenger RNA, then translated into structural proteins and nucleic acids, and new variants occur. So the attachment and the entry, fuse, uncoating, and release, and after that either transformed into messenger RNA or in RNA viruses or DNA viruses transformed into messenger RNA, or the RNA acts as messenger RNA, and in retrovirus they are transformed into double-stranded DNA, enters the nucleus, and transformed into messenger RNA, forming after that translated into structural proteins and nucleic acid and complete into new virins. This is the next step. After that is the eclipse and assembly. The viral nucleic acid enters into a capsid to be assembled into new virins. Eclipse and assembly, and then release. This is the viral replication. What about the inclusion bodies? The inclusion bodies are spherical, about 7 micrometer in size, and represent sites at which virus replication is occurring or has occurred. It's either intracytoplasmic, like pox virus, or intranuclear as herpes and papilloma virus. As we can see here, these are to the left the papilloma virus, intranuclear, and to the right is molluscum contagiosum, where we can see the inclusion bodies extracellular, or intracytoplasmic, and the herpes virus is intranuclear. So the papilloma virus, we can see the inclusion bodies intranuclear, and also the herpes virus intranuclear, and here the molluscum contagiosum intracytoplasmic. The molluscum, of course, is intracytoplasmic. A note about the sexually transmitted viral diseases. The sexually transmitted viral diseases, DNA viruses like herpes virus cause genital herpes and cytomegalovirus. The papilloma virus, condyloma acuminata, genital wart, and the pox virus causes molluscum contagiosum. RNA viruses, retroviruses like AIDS, and also there is the hepatitis B in this group. So there is sexually transmitted viral diseases: genital herpes, cytomegalovirus, condyloma acuminata, molluscum contagiosum, AIDS, and hepatitis B. Herpes virus group. Herpes virus group, they are DNA viruses that replicate intranuclear and with characteristic tendency to produce latency, i.e. after subsidence of the primary attack, the virus will not be eliminated for the body but remains dormant in one of the sensory ganglia. Reactivation leads to recurrence. So they are DNA virus, replicate intranuclear, and characterized by latency. The herpes simplex virus, we will talk about the definition, epidemiology, etiology, transmission and pathogenesis, complications, diagnosis, and clinical picture and treatment. Herpes simplex virus, especially the genital herpes or herpes progenitalis, the definition is chronic sexually transmitted viral infection characterized by asymptomatic viral shedding. Epidemiology, most common cause of painful genital ulcer. In USA, 22% of all people more than 12 years have herpes simplex virus 2 antibodies, or 45 million infected individuals, 1 to 5 in adults. The etiology, herpes simplex virus, double-stranded DNA virus, of which there are 2 types. Herpes simplex virus 1 affects the skin and oral mucosa. Herpes simplex virus 2, mostly genital areas, sexual transmitted. The genital herpes occurs mainly due to herpes simplex virus 2, 60%, and less commonly herpes simplex virus 1, 40%, maybe due to oral sex. And type 1 and type 2 antibodies have some cross protection. So the reduction in type 1 infection and antibody development during childhood may be a factor in increasing genital herpes. The transmission and pathogenesis, genital herpes occurs in young adults, 20 to 29 years after sexual intercourse, herpes simplex virus 2, anal coitus in male homosexuals, herpes simplex virus 2, and oral genital sex, herpes simplex virus 1. First, the herpes simplex virus is transmitted by close contact, skin-to-skin contact, with a person with shedding the virus, and with subsequent primary infection at the inoculation site. 3, herpes simplex virus ascends in the peripheral nerve, sensory nerve, and 4, to reach the sensory autonomic nerve root ganglion, where they establish latency. Latency can occur both symptomatic or asymptomatic primary infection. And the genital infection with herpes simplex virus 2 are associated with more asymptomatic shedding, higher rate of clinical recurrence, and higher rates of transmission. So the herpes simplex virus 2 associated with more asymptomatic shedding and higher rates of recurrence and transmission. We will say again now the pathogenesis. The herpes simplex virus are transmitted during close personal contact through the exchange of saliva, semen, cervical fluid, or vesical fluid from active lesions. The virus must contact mucosal surface or abraded skin, where the first replicates and initiate infection. The capsid then is transported into the neurons through the retrograde axonal flow to the dorsal root ganglia, where it replicates again to establish latency. The initial replication of herpes simplex virus 1 often occur in oropharyngeal mucosa and establish latency in the trigeminal ganglia. The herpes simplex virus 2 often replicates at genital mucosa, then establish latency at sacral sensory ganglia. The virus remains in an apparently inactive state for varying durations. Even the presence of intact humoral and cell-mediated immunity, reactivation can occur with a poor stimulus. The virus descends through the sensory nerve, then appears as a vesicle or ulcer at the mucocutaneous site. Recurrence are spontaneous, but there have been associations with physical or emotional stress, fever, exposure to ultraviolet light, nerve or tissue damage, immunosuppression, heat, cold, menses, concurrent infection, and fatigue. So this is the primary infection, skin and mucous membrane, the figure, and then it ascends through the retrograde axonal spread to the dorsal root ganglion, where it establishes latency, and then it can occur again, comes again into the wind stimulation. to be symptomatic as an ulcer or vesicle in the skin and mucous membrane. Of course, in herpes simplex virus 1, the first replication site is the oropharyngeal mucosa, and the dorsal root ganglia is trigeminal ganglion, and the herpes simplex virus 2, the first replication in genital mucosa, and the established latency at dorsal root ganglion, sacral sensory ganglion. We will talk about the asymptomatic viral shedding. The asymptomatic viral shedding, it's presence of human herpes simplex virus on mucosa or skin surface or in asymptomatic patients. It may be due to lesions in non-visualized areas as the cervix. It is the main mode of herpes simplex virus transmission, 60% of cases. It occurs mostly in first year after primary episode, then decreases in subsequent years. Most commonly in herpes simplex virus 2 than 1, most commonly in males, and increases with increased number of symptomatic recurrences 1 week after symptomatic recurrence, and decreases with suppressive therapy. So it is the presence of herpes simplex virus in asymptomatic patients, and could be due to hidden areas as the cervix. It occurs first year with herpes simplex virus 2 with male, and with more symptomatic recurrences, and is suppressed by suppressive therapy. There is risk of transmission. The risk of transmission increases of the virus increases with the increased number of sexual partners, age of first intercourse, and years of sexual activity, and other sexually transmitted diseases. Genital herpes, both primary and recurrence, mostly are asymptomatic. Less than 10% of all herpes simplex virus seropositive patient has reported history of genital herpes infection. We will talk now again about the viral shedding. It is continuous flow of the virus along the sensory nerve to the skin, from the sensory ganglia. So infection leading to infections and transmission of infection. Identification, either viral culture, isolation of viral DNA, or the PCR. Duration of shedding in the primary, 3 weeks. The recurrent is 3 days, or the secondary. 50% during the attack, 30% post-attack, and 20% pre-attack. So the viral shedding, it is a continuous flow of the virus along sensory nerve to the skin, leading to infection. The identification, viral culture, and PCR. Duration of shedding, primary for 3 weeks, and for the recurrent is 3 days. 50% during the attack, 30% post-attack, and 20% pre-attack. The treatment is chronic suppressive therapy. Now, this is what we were talking about in brief. The herpes virus, they are DNA viruses. Latency, reactivation leads to recurrence. Epidemiology, most common cause of genital ulcer, the herpes progenitalis, 1 to 5 in adults. Etiology, herpes simplex virus 1 in skin and oral mucosa, and herpes simplex virus 2 genital. There is some cross protection, and genital herpes is 60% of herpes simplex virus 2 and 40% herpes simplex virus 1. Transmission and pathogenesis, transmission with close contact, saliva, vesical fluid, semen, cervical fluid, abraded skin or mucosa. Pathogenesis, where the first replicates and initiate infection. Capsid is transported via the retrograde axonal flow to the dorsal root ganglion, which it replicates again to establish latency. The herpes simplex virus 1, the initial replication in oropharyngeal mucosa, the latency trigeminal ganglia. Herpes simplex virus 2, herpes progenitalis, genital mucosa, and the latency in sacral sensory ganglia. Reactivation leads to recurrence. reactivation with proper stimulus, which can be associated with stress, fever, GIT, upsets, sun, ultraviolet light, heat, cold, menses, immunosuppression, nerve and tissue damage, infection, and fatigue, leads to recurrence. The virus descends through sensory nerve and then appear on vesicles or ulcer as a vesicle or ulcer in mucocutaneous site. So this is the herpes simplex definition and epidemiology, etiology, transmission, and pathogenesis. We will talk about the complications. Complications: psychosexual problems and depression, urinary retention, either reflex due to severe pain during micturition in cases of intraurethral affection, or radiculitis affecting sacral segment. Secondary infection, delay healing and scarring, and severe infection of produce lead to phimosis. In immunocompromised host, there is cutaneous dissemination or systemic spread, and also there is the neonatal genital herpes, and there is aseptic herpes simplex virus 2 meningitis, fever, headache, vomiting, and photophobia, and cancer cervix, which is new studies failed to prove this connection with herpes simplex virus 2 to cancer cervix. So the complications: psychosexual problems, urinary retention, secondary infection lead to scarring, and severe infection lead of purpose lead to phimosis, immunocompromised host cutaneous dissemination and systemic spread, neonatal genital herpes, aseptic H2 herpes simplex virus meningitis, and which is not proved to be cancer cervix. We will talk about herpes simplex virus and HIV disease. Genital ulcer provides a portal of entry during contact with HIV in infected secretion, and also the inflammatory response, the CD4, which is associated with genital ulcer, it is the target of HIV infection. So it is improves the portal of entry by the genital ulcer, and also the target of HIV infection, which is the CD4. Ulceration of genital herpes is more important than the syphilis and chancroid in HIV spread, because genital herpes is more common cause of genital ulcers, and also genital herpes frequently recurrent. So most likely the skin to be broken and susceptible to HIV infection. So this is the association with herpes simplex and HIV disease. The diagnosis of the herpes simplex virus: for the asymptomatic viral shedding, as we said, tissue culture and PCR. For the herpes simplex virus, tissue culture, PCR, Zank smear biopsy, and specific serological test as Western blot and direct fluorescent antibody binding assays. The tissue culture can differentiate between herpes simplex virus 1 and 2. The PCR also can differentiate between herpes simplex virus 1 and 2, but more sensitive, 2 to 3 times. The Zank smear can differentiate between herpes simplex virus and zoster. So the tissue culture, HeLa cells, can differentiate between herpes simplex virus 1 and 2. Material is obtained for the culture obtained from fresh vesicle, sterile cotton wool swab, better than calcium alginate in contrast to gonorrhea, by rubbing over the base of the lesion, so there is adequate serum is obtained, and the tissue culture is less reliable as the lesions mature and develop ulceration and crusting, so it's better to be a fresh vesicle. Zank smear can differentiate between herpes simplex and herpes virus. There is multi-nucleated giant cells showing ballooning degeneration of the nuclei. And the biopsy, we will see typical herpes simplex as the herpes simplex, and PCR, more sensitive than the culture, can differentiate between herpes simplex virus 1 and 2. Specific serological tests, Western blot most specific, and direct fluorescence antibody binding assay, but they are expensive. Herpes simplex virus antibody appear at 13 days after the person becomes infected. in primary infection. In recurrent infection, genital herpes can be ruled out if herpes simplex virus type is negative. So if negative, it is in recurrent genital lesion, it could be ruled out if it is negative. Herpes simplex ruled out if it is negative. Main function to differentiate between primary and recurrent infection. Useful for patients with recurrent herpes simplex genital lesion that are not presenting during examination. Culture cannot be obtained. So there is the tissue culture, Zang smear, biopsy, PCR, and specific serological test for syphilis. As we can see here, this is actually the biopsy of herpes zoster, not the herpes simplex, but they are and this is what we said about the primary and lesion and the dorsal root ganglion and the latency. The pathology of the herpes simplex virus and also herpes zoster, which is varicella, and herpes zoster, the two viruses cannot be distinguished by routine H&E. So they are the same in histopathology, they are the same. They cannot be distinguished by routine H&E. As we can see here, in the epidermis, there is intraepidermal vesicles, acantholysis, and reticular degeneration. And in the dermis, there is edema and vasculitis. Intraepidermal vesicle, acantholysis, reticular degeneration, dermis, edema, and vasculitis. There is ballooning degeneration with formation of intranuclear inclusion bodies and multinucleated giant cells. Ballooning degeneration with formation of intranuclear inclusion bodies and multinucleated giant cells. The nucleus contains sharply eosinophilic inclusion bodies. So there is sharply eosinophilic inclusion bodies that is separated from the deeply basophilic ring of marginated chromatin at nuclear membrane by nuclear halo or cleft. So the nucleus contains sharply eosinophilic inclusion bodies that is separated from deeply basophilic ring of marginated chromatin at the nuclear membrane by clear halo. This is the histopathology of the herpes simplex and of the herpes zoster viruses. We can see here also this is the same as we can see in the epidermis and dermis. Here we can see in the epidermis intraepidermal vesicles, acantholysis, and ballooning degeneration, and in the dermis there is edema and vasculitis. And we can see here the multinucleated giant cells with the nucleus has the highly eosinophilic inclusion body with the surrounded by nuclear halo and with the deeply basophilic ring of the marginated chromatin. This is the pathology of both the herpes simplex and herpes zoster. And here other pictures also we can see, and here's also the as we can say that the two viruses cannot be distinguished by routine H&E. There is intraepidermal vesicular ulceration, acantholysis, epidermal necrosis and ballooning degeneration, and there is the herpetic cytoplasmic changes are enlarged and pale keratinocyte with steel gray nuclei, margination of chromatin at the edge of the nucleus, sometimes with pale intranuclear inclusion bodies surrounded by artificial clefts. And there is acantholysis and multinucleated giant cell. As we can see here, low magnification, and here medium magnification, and other pictures here in the high magnification, and the lower picture of the vasculitic changes of the neutrophil nuclear dust and vascular necrosis and red blood cell in lumen and collagen. Neonatal herpes simplex The neonatal herpes simplex or genital herpes during pregnancy may lead to either congenital infection or neonatal infection. 1% of patients in prenatal clinics have herpes simplex virus 2. We confirm by culture, and 1/3 of them have lesions. Either they are congenital infection or neonatal infection. The congenital infection through transplacental transmission, and this is rare, and the neonatal infection, the mode of transfer is through either the mother during passage from the birth canal and direct contact with the maternally shed virus, or either medical and nursing staff and other babies. So the congenital is through the transplacental transmission, and the neonatal either from the mother or the medical personnel. Now, for the congenital infection through transplacental transmission, which is rare, either it occurs either early, leading to fetal death and spontaneous abortion, or extremely rare, it happens late in pregnancy and leads to fetal serious multisystem disease, as growth retardation, psychomotor retardation, microcephaly, widespread recurrent vesicular eruption that may resemble epidermolysis bullosa. So the congenital infection, it's rare through transplacental transmission. Early, it occurs fetal death and spontaneous abortion. Late, it causes fetal multisystem, serious multisystem disease. For neonatal infection transmitted through the mother during passage from the birth canal and direct contact with maternally shed virus or medical and nursing staff and other babies, it can be either localized lesions like the skin, eyes disease, mouth disease, or sometimes scalp and buttocks, according to type of delivery or mode of delivery. It starts a few days after the delivery, and or could be also disseminated infection with encephalitis, which is fatal. So it is either localized or generalized or disseminated and with encephalitis, which is fatal. The neonatal infection can occur if the mother has active herpes at the time of delivery, either with symptoms or without symptoms, asymptomatic viral shedding. Increased risk of neonatal infection, especially primary maternal attack in third trimester or at delivery. It is more than 50%. If the primary herpes occurs in third trimester or delivery, it is more than 50% that occurs the neonatal infection. But for recurrent maternal episodes, it is less than 8%. So some advice for a cesarean section anyway. The management for the pregnant woman. Cesarean section may be considered if the pregnant woman has active lesion at the onset of labor, or if in the third trimester, especially 6 weeks from labor. There is risk of viral shedding in labor is very high. If it is unavailable, acyclovir treatment of the mother and baby may be indicated. So cesarean section indicated in pregnant woman if active lesions at the onset of labor, or if she requires the infection, primary infection in third trimester, especially 6 weeks from labor. And we give acyclovir also in women infected during the first and second trimester. Continuous acyclovir from the last 4 weeks of pregnancy may prevent recurrence at term and hence needs for cesarean section. So this is the management of the mother. For the neonate, we give either at risk, we isolated, kept under supervision, and prophylactic acyclovir sometimes. The established neonatal disease, antiviral therapy by acyclovir or vidarabine reduces the mortality. This is the neonatal herpes simplex, either congenital and neonatal infection, with the management of both mother and fetus. Clinical picture of the herpes simplex virus, the progenitalis and also the other types. The clinical picture, there are 2 types of clinical of the disease or the infection. There is the primary infection and there is the recurrent infection. The primary infection refers to the first infection with either herpes simplex virus 1 or 2 in individuals who do not have antibodies against their herpes simplex virus 1 or 2. There is no neutralizing antibodies. So it refers to the first infection with the virus either 1 or 2 without having any neutralizing antibodies. And the secondary or recurrent infection, it is less severe and not due to reinfection. It occurs after the virus already has established latency in the sensory ganglia. Precipitating factors, stress, sex, menstruation, and trauma. But for herpes simplex virus 1, other factors like fever, sun exposure can also be important. But in 2, it is herpes simplex virus 2, it is heat, labile, and fever rarely causes its recurrence. Prostaglandins are the mediators of this process. 90% of primary symptomatic will recur in first year after primary attack. Interval between initial and recurrent infection about 120 days, of range of 25 to 365 days, and about from 1 month to 1 year. Rate of recurrence, it depends on the viral type. It's more in herpes simplex virus 2 than herpes simplex virus 1. Herpes simplex virus 2 usually occurs, recurrence is earlier after primary infection, and usually it is the recurrence rate is 4 per year. For herpes simplex virus 1, it is 1 per year. So this is the recurrent infection. Clinical picture of the herpes progenitalis, the primary attack or the primary infection to the left and the recurrent infection to the right. The primary infection, as the first attack is seronegative, patient usually present with multiple painful genital ulcers. Usually is manifested by multiple painful genital ulcers. Lesions start with erythema and progress to vesicles after about 6 to 10 vesicles, and then ulcers, then crusts. Erythema, vesicles, ulcers, and crusts. Prodroma, of course, there is prodroma, very important, of fever and malaise in 70%. Prodroma in 70%, fever and malaise. Primary attack usually manifested by multiple painful genital ulcers. Lesions start with erythema, vesicles, ulcers, and crusts. Most patients have inguinal lymphadenopathy, and there is other things like discharge and dysuria. Discharge from rupture of intrameatal vesicles. The whole illness for about 3 weeks unless secondary infected. In males homosexuals, there is rectal affection, blood and pus in the stools, and there is also tenderness and constipation, even intestinal obstruction. Vulva and perineum in females, vulva and perineum, lesions similar to the males, and rarely vagina and cervix. Lower abdominal pain and fever with discharge, dysuria, and dyspareunia. So the primary herpes progenitalis, the first attack in seronegative patient, usually present with multiple painful genital ulcers. There is prodroma in 70% of fever and malaise. Lesions start with erythema, progress to vesicles, about 6 to 10 vesicles, ulcers, and crusts. Most patients have inguinal lymphadenopathy, discharge, and dysuria. Stays for about 3 weeks. And for the secondary or recurrent attack, there is small recurring groups of vesicles on erythematous base. So there is groups of vesicles on erythematous base. Less irritation and heals more rapidly, about 1 to 2 weeks. Vesicles is replaced by crusts. There is no prodroma of constitutional symptoms, but there is prodroma of only local tingling and paresthesia for 24 hours or 48 hours. It lasts for only about 1 week and 1 to 2 weeks. So this is the small recurring groups of vesicles on erythematous base. The herpes progenitalis, clinically for the primary attack and for the recurrent attack. And this is the clinically primary genital herpes with vesicles and primary herpetic vulvitis. Now we will shift to the herpes simplex, primary and recurrent. The herpes simplex, the primary attack, the first attack of the seronegative patient, usually subclinical and passes unnoticed but can be asymptomatic and present with large vesicles with no tendency for grouping. Large discrete vesicles, no tendency for grouping. Usually it occurs in children 2 to 5 years. There is fever and malaise, and lesions start with erythema, vesicles, ulcers, and crust. Regional lymphadenopathy. Other manifestations like edema, fissures, ulcers, and pustules. There is spontaneous resolution within 1 to 2 weeks with normal skin. For the recurrent cases, it is small grouped vesicles on erythematous base. Less irritation, heals more rapidly. Vesicles replaced by crusts, heals about spontaneous resolution within 1 week with normal skin. Prodroma of no local tingling and paresthesia, no constitutional symptoms, no regional lymphadenopathy unless secondary infected. So this is the primary and second and recurrent of the herpes simplex virus. Clinical variants there is occur in primary or recurrent herpes simplex virus. The herpes labialis or facialis is the commonest, the congenital and genital, and gingivostomatitis keratoconjunctivitis, eczema herpeticum or Kaposi varicella eruption, zoster herpes simplex, eczema vaccinatum, post-herpetic erythema multiforme, and inoculation herpes simplex or herpetic Whitlow. And there is other types like herpetic folliculitis, herpes simplex pneumonia, and herpes simplex encephalitis. So we talked about congenital and genital, congenital herpes simplex and genital herpes simplex progenitalis. And then there is the herpes labialis or facialis, which is the commonest. Lips are most frequent site. There is the nose, cheeks, and ears also may be effective. Another type is gingivostomatitis, entire buccal mucosa with marked erythema and edema of gingiva, keratoconjunctivitis, the cornea, corneal ulceration, and scarring. The eczema herpeticum Kaposi varicella eruption, infection usually with herpes simplex virus 1 in patient with pre-existing dermatosis like atopic dermatitis, seborrheic dermatitis, diarrheal disease, benign familial pemphigus, pemphigus foliaceus, mycosis fungoid, Sézary syndrome, ichthyosis vulgaris. It occurs both in primary infection in infants, children. There is viremia and systemic affection and sometimes death. And recurrent infection, there is no viremia, no internal organ affection, and no death, except in immunocompromised patients. Clinically, there is extensive eruption of vesicles and pustules that may be umbilicated, mainly on areas of pre-existing dermatosis. Face usually severely infected with marked edema. There is fever and prostration. Eczema vaccinatum, it is due to accidental inoculation of vaccinia virus, which is no longer seen clinically like eczema herpeticum. And there is the zostriform herpes simplex, which is very difficult to differentiate from herpes zoster. Herpes simplex in immunocompromised host. The herpes simplex in immunocompromised host, disseminated herpes simplex, it occurs in patient with low cell-mediated immunity, either from congenital disease like Wiskott-Ardlich syndrome and dysplasia of thymus, and there is other diseases like lymphoma, leukemia, severe burns, and AIDS. Manifestations, 3 types: chronic ulcerative herpes simplex, generalized acute mucocutaneous herpes simplex, and systemic herpes simplex. The chronic ulcerative, there is persistent ulcers and erosions start on the face or perineal area, and it can shift to the other 2 types, the generalized and or the systemic herpes simplex. So there is maybe widespread extension or systemic herpes simplex may occur. This is the chronic ulcerative herpes simplex. It is chronic ulcerative herpes simplex in perineum has also described in male homosexuals and AIDS patients. And generalized acute mucocutaneous herpes simplex, start localized vesicular eruption, could start localized in genital area in herpes simplex virus 2 or other areas herpes simplex virus 1, and then there is rapid dissemination associated with fever, suggestive of varicella or smallpox. Death may result without even visceral lesions. Systemic herpes simplex, it follows oral or genital herpes simplex. There is areas of necrosis of the liver, adrenals, and pancreas leading to death. So the herpes simplex in compromised hosts, disseminated herpes simplex, it occurs in patients with low cell-mediated immunity like congenital diseases, lymphoma, leukemia, severe burns, AIDS, and prolonged immunosuppressive therapy. Manifestations, 3 types: chronic ulcerative herpes simplex, generalized acute mucocutaneous, and systemic herpes simplex. Chronic ulcerative, persistent ulcers and erosions that start on the face or perineal lesion could be widespread extension, or systemic lesions may occur. Generalized acute mucocutaneous, it starts localized vesicular eruption, either herpes simplex virus in genital area or 2 or herpes simplex virus 1 in other areas, with rapid dissemination and associated with fever. Systemic herpes simplex virus, it follows also oral or genital and leads to areas of necrosis to the liver, adrenals, and pancreas, leading to death. There are other 2 types of the herpes infection. Herpes simplex virus infection, zostriform herpes simplex, we said zostriform. Now there is the inoculation herpes simplex, which is the herpetic whitlow. The herpetic whitlow is a painful deep-seated vesicles in distal phalanx of the finger caused by herpes simplex virus 1 or 2, and maybe mainly in medical personnel. And also there is the post-herpetic erythema multiforme, usually occur within 9 days. There is rare types like herpetic folliculitis in beard of males, and herpes simplex pneumonia, which is fatal, and herpes simplex encephalitis. These are the main types of or clinical variants of the primary and recurrent herpes simplex virus. Herpes labialis, facialis, gingival keratoconjunctivitis, congenital or neonatal herpes simplex, genital herpes simplex or herpes progenitalis, and there is post-herpetic erythema multiforme, inoculation herpes simplex or herpetic whitlow, eczema herpeticum, capucivariform eruption, or zostriform herpes simplex virus, and also there is eczema vaccinatum, and there is the herpes simplex in compromised host, which is the disseminated herpes simplex, either chronic ulcerative or generalized acute or systemic herpes simplex. Other types of herpetic folliculitis, pneumonia, and encephalitis. We can see here clinically, this is the herpes progenitalis, and here there is the herpetic whitlow to the left, and to the right is eczema herpeticum in atopic patient. And here we can see herpes simplex virus on the face, and recurrent herpes simplex virus here also, and here perioral herpes simplex. We can see here also herpes simplex virus. The first is primary gingival stomatitis, and here the other one is recurrent. Here we can see the primary lesions of herpes simplex, herpetic gingival stomatitis, and we can see here the recurrent lesions of the herpes simplex of grouped vesicles and crustaceans.